last lecture for today with Mr. Samir Abu Ghazala, Director, Patient Experience Division in IMC Jeddah. He's going to speak to us about the patient experience themes from the International Medical Center, Design, Culture, and Process Improvement. Please join me in welcoming him to the stage. You want this?
Bismillah ar-Rahman ar-Rahim. Alhamdulillah, wassalatu wassalamu ala Rasulillah. Thank you so much for Mr. Malik Al-Musa for the invitation, and for Al-Musa family, for Muna and everybody who has worked very hard in making this event a success. I'm extremely impressed. It's really a wonderful, inspiring event, and I salute you all for the hard work and congratulate you for an amazing event. Patient experience at the International Medical Center has passed through the hands of 3 leaders sitting in this hall. Mr. Adil Al-Shab'an, Mr. Abdul Aziz Abdul Bagi, and Mr. Samir Abu Ghazala. So we are very lucky to be in the same room. It was not planned. So it gives the organization truly its representation. Oops, pushed the wrong button, I guess. Can we put it back on the? So we'll talk about definition of patient experience, design elements, and patient experience. Are you ready for a chief experience officer? And that's something that many people are not really sure about. Should we have a chief experience officer? Are you working on accessibility and Six Sigma projects in your organization? For me, access to care represents 50% of patient experience. If you can access your care in a timely manner, you have achieved 50% of patient experience. Do you have a patient and family advocacy committee? Do you have patients in other committees? Are there committees in the hospital where patients are represented in? What do patients want? And do you have weekly messages to the staff about patient experience? And what is the voice of the customer, and how do you measure it? To start with the International Medical Center, when we re-energized the patient experience department, I came back to the International Medical Center a year and a half ago. There was a lot of concepts that are running around between quality, process improvement, and patient experience. And there was no clear vision to march ahead. So we started having collective brainstorming sessions with the team on how do we define patient experience. And we used some of the references that were used. And there's patient experience is a new phenomenon in many hospitals. Cleveland Clinic was the pioneer in 2007, 2006, 2007, when they appointed a chief experience officer. So it's a new phenomenon. And how do you bridge the gap between quality, process improvement, and patient experience? And last week I was in Cleveland Clinic in a forum on patient experience, and I asked a question to the chief experience officer, Dr. Boise. Do you feel that at any certain point the quality department might swallow the patient experience department? Because it's a new phenomenon, you know where the direction is. And the answer came strong and clear. Patient experience is a movement. It's a strong movement in the whole world, and it will survive, and it will make an impact on hospitals and patients. Definition: patient experience, according to the Beryl Institute, is the sum of all interactions shaped by an organizational culture that influence patient perceptions across the continuum of care. Deloitte recently published a paper on patient experience and defined patient experience as the patient experience refers to the quality and value of all interactions, direct and indirect, clinical and non-clinical, spanning the entire duration of the patient-provider relationship. The International Medical Center started with a strong concept with the design elements. We do strongly believe that evidence-based design does affect the health and well-being of the patient. From the moment the patient enters the hospital until they leave it, high ceilings, access to natural light, and greenery are proven scientifically that they reduce anxiety and blood pressure of patients. And a welcoming environment into the hospital does give the patient a less anxious feeling. You know the white coat effect. Once they start seeing the doctors and the white coats and the syringes, the blood pressure goes up, the anxiety increases. So we need to have design elements that reduces these elements. I'm just going to go through some of the pictures, the uses of poetry and the uses of verses from the Quran at the entrance of the hospital does give the patient a feeling of connectivity to the culture. They're not coming to a black and white walls that have no connection with this human coming in. Do buildings speak to people? They do. Do buildings welcome or repel people? They do. Do buildings welcome you with high ceilings, access to natural light, greenery, fountains, and a good feeling? They do. Is this the only thing? No, it's not. And we'll focus on that at the end. This is the entrance, the lobby of the International Medical Center. This is the internal garden that we spend a lot of money on maintaining and keeping within the International Medical Center. Living in a desert, so irrigation, water, and maintaining flowers is a very difficult matter in this country. We have a single room in the whole hospital. We don't use double rooms. Our CEO is very adamant on that. And this is not to the pleasure of the insurance companies. Our CEO is very adamant that if you share rooms, you might increase infections. You might increase anxiety. A patient coming in, a patient leaving the OR, vomiting and not sleeping at night will affect a patient who's just coming in with all of these anxieties. So the holistic approach, mind, body, and soul, was instilled in the whole organization. And this is our mission, pioneering a unique approach to healing, not treating, healing the mind, body, and soul through international healthcare standards and divine ethics. A huge 260 square meters mosque within the organization. Many people, when they come in, they say, oh, what a waste of space. No, it's not. We're not treating an MRN number. We're treating a human being. We are educating their minds, we are respecting their bodies, and we are spiritually infusing a spiritual strength into these patients. A place for women to walk before pregnancy, to expedite pregnancy. Fountains within the hospital. These are some examples of the hospital, but this is just the beginning. By the way, I've lived in the IMC since we started. And guess what? Building a hospital is the easiest part. The construction was the easiest part. I thought to think that it's the hardest part. The hardest part is really infusing the right staff, the right emotional experience, and the right spiritual experience within the culture. So hospitals and healthcare systems need to address not only the physical journey of the patient experience, but also the emotional one. Diagrams visualizing the emotional path of patients are also vital. Are you doing that? Are you drawing the emotional experience of the patient within the organization? So what is patient experience then? All of these things are still all over the place. People are defining it in different ways. As Adil said, people have different missions and visions in different places. In my book, patient experience starts with culture. A culture of trust, a culture of humility, a culture of transparency, a culture of communication, a culture of leaders, and everybody else in the organization is a caregiver. No rank. Everybody is willing to jump in and help. Oh no, Mr. Samir, you shouldn't be helping me, or the director. I'll call on the manager. No, I pull up my sleeves and I start helping. There is no rank when it comes to helping and supporting a patient, or even pushing a patient in a wheelchair. Clinical excellence is patient experience. Operational efficiency is patient experience. A lot of people mistake patient experience as the concierge at the door. It's not. It's part of it. Patient experience is all of this. Patient experience is discharge preparation, clinical skill, pain control, environmental rounds, waiting time, amenities. Patient experience is empathy. Patient experience is privacy. When I came back to IMC, I discovered that there is no service recovery policy. Do you have a service recovery policy in your organization? I initiated it today. The patient came, had issues, and we offered him a free visit, a free counseling. You have to have a service. Why do hotels have service recovery policies and hospitals don't? When you go to a hotel, you're not that stressed. So when you receive a service recovery in a hotel, it's more of a priority to have service recovery within the hospital. I'm happy to share the service recovery policy with people who need it. So what is patient experience again? It's the 3 Ps. It's people, it's processes, it's the place. It's all of these things interacting with each other. It's not the place alone, it's not the people alone, it's not the processes alone. All of these communicating with each other build proper patient experience. I recommend reading this book. If Disney ran my hospital, and those of you who have gone to Disney, I could not drag my kids out of Disney after I've taken them in. We spent 12 hours. It was enjoyable. I had fun. I ate cotton candy until I couldn't stop. It's a pleasant experience. Why can't we make hospitals a pleasant experience? Why does the patient has to come into the hospital and feel anxiety from the minute they come in? Why do we scare our kids telling them that nurses, I'll bring the nurse to give you an injection? Hospitals became the boogeyman center or boogie woman center, scaring kids with it. Why are we doing this? Why can't we switch hospitals to become, and in the book, the gentleman speaks about silos a lot. Silos are a huge problem in hospitals. Healthcare is a very complex industry. And if you do not, many people say, and I made a mistake of saying this in front of a friend of mine, break the silos. If you don't break the silos, you cannot have a good culture. He said, no, Samir, you don't break the silos. You join the silos. So as a leader, do you join silos or do you break silos? The word breaking is very negative. Yesterday, His Royal Highness, the King of Saudi Arabia, in a conference, and I was about to put the picture, but I refrained, held an old Nokia and an iPhone. Did you see that? He said, I want to switch Saudi Arabia from this culture of Nokia to the culture of the iPhone. We're moving to the future. And in the book, this gentleman speaks about selling experience. We're not selling OR packages, as they call them. We're not selling visits to the executive clinic. You're selling an experience. Why don't you sell an experience in the hospital? Who can live without an iPhone or a Samsung now? I have my social media, I have my bank access all the way to the US and all the way to Jordan, all the way to Jeddah through my hand. Why can't the patient have access to their medical record data? Why can't they book an appointment on their phones? So everybody worked on an experience, and we're still in healthcare lagging behind. And a lot of people, and I definitely agree, it's not about the marble and the wood in your hospital. It's rather about the roots that you build in your culture. And I borrowed this from the late Dr. Floyd Loop, the ex-CEO of Cleveland Clinic, whom I learned a lot from. And he says, your roots are the mission, the dedication, the teamwork. So what's culture? We were discussing what's culture. Your roots are the skills, the innovation, character, and networking, ethos, satisfaction. I thought I'm running out of time. So are you ready for a chief experience officer? Ask yourself this. Are you ready to agree that this person is the chief of culture? That he or she will definitely influence culture in the organization? If you're not, if you're going to give culture to the HR department and keep it there, rethink having a chief experience officer. Are you willing to provide unwavering support to stay the course and make the changes that the chief experience officer is asking for? If not, get ready first. Are you ready to believe employee and physician engagement is the foundation to long-term patient experience? Are you ready to empower the leaders in patient experience, and on and on? Are you ready for all of these things? I think you should be ready. I think from today's conference, I repeat again, patient experience is a movement, and it will not stop, and it will prevail. Because patients deserve that. So silos, everybody's talking about silos. And I would not tell you otherwise. Every single hospital has silos. HR, IT, finance, the medical division, the doctors with the egos, and how do we join the silos? I love doctors, don't get me wrong. So how do we do that? How do we join the silos? And then worse, how do we speak to the leadership and their ivory towers? How do we reach to the leaders? I love leaders. I'm one of them. I live in an ivory tower sometimes, don't get me wrong. But how do we do that? There is a glass wall around leaders sometimes. I'm busy, I have meetings. I cannot connect with the frontliners. I cannot empower the frontliners because I didn't even understand what they do. We'll go live with them and understand what they do. Otherwise, you can't be a successful leader. I believe patient experience can join the silos. I believe patient experience and the team of patient experience, when they break the silos, can break the glass wall around leadership and bring them down to reality. So I started the patient and family advisory council in the hospital, and I invited an MS patient. Amazing story. She came as a complaint, and she became an advocate of the hospital now. But I needed to market it to the staff. And I needed to market it to the patients. It's very difficult to convince a patient to come like the wonderful patients that spoke today. But it happened, and the MS patient changed a lot of things in the hospital. You move in our hospital and you find a rail behind the seat in the bathroom and a rail to the left side. I've been living this in the hospital for 10 years. But she came to me and she said, Samir, I'm an MS patient. I lost movement in my left hand and I cannot stand. You don't have anything on the right for me. 10 years, our handicapped bathrooms did not have anything on the right-hand side. 10 years, and nobody noticed it. And these poor patients have been going through this pain. I installed rails in most of the handicapped bathrooms now. Small thing can change the life of many patient groups. So it's about the continuum of care. It's about the reputation of your hospital. It's about the arrival contract that you make with the patient, the stay in the hospital, the treatment, and post-discharge calls. Do you make them? What do patients want? I want to feel informed, be given options, and take part in the decision about my health. I want to listen and spend time. I want you to listen and spend time with me. I want you to treat me as a person, not as a medical record number. I want you to tell me about support services that make my experience easier in the hospital. You know, we take care of the big things, but the small things, parking, who cares? Ensure continuity of care. Tell me about the care plan. What will happen next? We're left hanging sometimes. We give the treatments, they go in the PACU, and they're forgotten. Or they go home after a major surgery and nobody does a post-discharge call to see if they're bleeding or have infection. Provide efficient processes so that I only have to tell my story once. Communicate, communicate, communicate. Major disease in hospitals is communication. No communication between doctors and nurses, no communication between nurses and frontliners. And in Saudi Arabia, it becomes even more profound because you have hundreds of nationalities within one hospital. Nurses are mostly from Philippines, doctors are mostly Arab, frontliners are Saudi, and you have this mix. Unless you establish a strong culture of caregivers, this is the only nationality they should have, you can't succeed with that. And this I was reading in the book from the Cleveland Clinic Way about the emotional bank. These are my weekly messages to the organization. The emotional bank, it tells you that the human being has a certain level of emotional ability to absorb. How long do I have? 4 minutes. I'll rush. So the patient comes to book an appointment. They call the call center and they make the appointment. 100%. The battery, or the emotional battery, is still charged. They come to look for parking and they don't find parking. They go around the hospital 10 times and they can't park. And they park far away and they are handicapped, so they face problems. 20% is lost from the emotional bank. The patient waits for a long time for insurance approval, another 20%. The patient is treated without caring in the triage area, another 20%. The patient waits for the doctor and then they tell him at the reception, oh, the doctor went to the OR, we apologize. He cannot see you today. And then complaints department gets involved. And then you call Mr. Strong because the patient becomes violent and aggressive and starts screaming, and then we blame the patient. That's the story of most of the hospitals. This is an example of experience that any patient could encounter. Please help our patients by satisfying them before they lose their patience. And you start blaming them. These are the weekly messages. And the ready approach, by the way, I just passed it. The ready approach speaks about relationship-centered care. It should not be patient-centered care. It should be relationship-centered care. Because if you have a burned out, and they changed the name of burnout now, it became compassion fatigue. If you have a doctor or a nurse with compassion fatigue, and then you expect a good patient, because you work them 12 hours a day, and then you expect good patient experience, revisit that. We have all of these messages that we send weekly. We define empathy. And Dr. Cosgrove, last week in the forum I attended in Cleveland Clinic, he established the patient experience department because he went to Harvard bragging about Cleveland Clinic, and a patient stood up and said, Dr. Cosgrove, I took my father to Mayo Clinic because I learned that your doctors in Cleveland Clinic are not empathetic. They don't care about the patients. So I took them to Mayo where they have more empathy. And he was shocked. He said, I thought I was the #1 cardiology center in the United States, but I was missing empathy. So the lady asked him, so how do you teach empathy, Dr. Cawthorne? How do you teach empathy in your hospital? And it's still a question that I'm grappling with. How do you teach empathy? How do you teach caring? Starts from the selection process by selecting the right people, but it goes all the way down to really teaching people skills, give them tools. If a person is faced with a complaint, what do you do? Well, we apply, and we borrowed it from Cleveland Clinic, the HEART methodology. Hear, empathize, apologize, respond, thank. The HEART methodology. So there are tools you can give to your good staff that you hired and returned to help the patient survive. All of these messages are sent on a weekly basis to the staff. And then how do you measure satisfaction? I'll go through these very fast because I think I'm out of time. We have many ways of measuring our satisfaction, and we have identified the top 10 most pressing complaints in different areas in the hospital, whether it's in OPD or or insurance or other places. We listen to the patients, so we get their positive and negative remarks, and we hear a lot of good and bad things, normal for hospitals. People are shy to talk about malpractice and about, well, things happen in hospitals and you have to know how to deal with it. And then after a patient visits the hospital, I think it's my brother Abdul Aziz who initiated this process in OPD, Jazakallah khair, it's still running. We did not drop it, great initiative. We send a message to the patients by phone, and we measure caring. And alhamdulillah, lately we have been improving the caring process in the whole OPD. Recently we have installed iPads where every patient who deals with a receptionist has the picture of the receptionist on the iPad, and they measure them on caring only. Was this receptionist caring for you or not? So it's an iPad that gives immediate, and I was going to do a generic one, but Dr. Walid said, no, Samir, I want, instead of you and HR evaluating the receptionist unfairly, I want the patient to evaluate the patient. I want the patient to come and do the evaluation himself or herself, because you could be biased and subjective. You don't know how good or bad that receptionist is, and evaluating them on top with a piece of paper might not be fair. And we do the same with the nurses. Our CEO wants to measure caring. We measure if a nurse covers 4 rooms in the inpatient, my staff goes, gives them an iPad. We don't do it. We give them the iPad, and we say we will not know once you push submit what happened to your evaluation. Only the management will. And only measure our nurses in terms of caring. Our current chief nursing officer, and the results, alhamdulillah, are great, but our current chief nursing officer, if he sees out of a pool of 800, 900 people, if he sees a 0 or anything below 5, he sees it live, by the way, on his computer, he immediately leaves his office and goes to visit that patient. We initiated, based on the voice of the customer that you have seen and the different patient satisfaction surveys, we initiated 8 Six Sigma projects. OPD session slot utilization, scheduling, and access, common for many hospitals. If you improve them, you improve access and you improve patient satisfaction. ER improving flow and reducing crowdness. Inpatient discharge delays, we have an issue with that. Inpatient coordination, OR scheduling, we do have an issue with that, and we have improved it through the project. And human resource management project. With this, I'm done. Last 2 slides. With that, we suggest that patient experience is at the foundation of all we do in healthcare. It shapes who we are as an organization. It guides our actions and behaviors. It directs the choices that we make, and it frames how we engage with those who make up our organization and those in our care. With all this at stake, we cannot and should not risk having that purpose remain undefined. This leads to potential consistency and misuse. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. Definitely. Thank you so much for your time.